Welcome to the NeoFOCUS-UK Education Group webinar series.
So thanks all for joining today. It gives me quite a lot of pleasure to introduce Ramon. I feel quite lucky being in this position because I've got to introduce two people who really probably put me into neonatology, which is Ramon and also Heike, who previously presented. So Ramon is an associate professor at Brighton and Sussex Medical School and is an honorary consultant at the Trevor Mann Baby unit in Brighton. So he trained in Germany, in Gießen initially, and then moved to Berlin, and then also on to Brighton to train. He has an extensive training background in paediatric and neonatal ultrasound, including echocardiography. He's recognised with a PG cert in advanced medical imaging as well. So is well qualified to be certainly discussing the topic of today, which is, I know he has a special interest in, which is the current and future practice of ultrasound in necrotizing enterocolitis. So I can see that we've got lots of people joined already, and I will hand the floor over to you, Ramon, if that's okay.
Thank you, Liam. Thank you for inviting me. Can you hear me okay?
Can hear you fine.
Okay, perfect. Thank you. Oops. So I'm sure I don't need to tell you that NEC is a devastating condition with high morbidity and mortality. I think that's pretty clear to all of us. And as always, we would like to kind of improve that and believe that maybe early recognition and management is likely to be associated with a better outcome. However, with regards to NEC, we have a few problems. We have a difficulty to diagnose early, no matter what we do at the moment. We have a difficulty to establish a failure of medical treatment. And we have difficulties identifying those early signs of ischemia or necrosis and the need for surgery. So what I'm going to talk to you about today is basically go through the pathophysiology of NEC and its image correlates, review the technical and practical requirements for NeoFOCUS, and then review the indications for NeoFOCUS and discuss that a little bit more. Look at NeoFOCUS findings or images, which is the main part of my talk, and then at the end finish with maybe a future outlook. Well, some of the techniques are already in place, and I have used some of them. Discuss trends in NeoFOCUS and where this journey might be going. This is a simplified sketch of radiographic and ultrasonographic findings in NEC with correlation to its pathophysiology. It was published in Archives in 2019, and you can see there that the red framed boxes show the pathophysiological processes. The black framed boxes demonstrate the imaging correlates. Where you have a white eye, this is something you can see on ultrasound, so where you can see change in ultrasound, and where you have a black eye, visualization is on abdominal X-ray. As you can appreciate, the onset of NEC is characterized by inflammation with mucosal edema and increased blood flow, so I'm not telling you anything new here. On abdominal ultrasound, this presents with progressive bowel wall thickening and increasing echogenicity of the bowel wall, and a hyperemic appearance on color Doppler. Then bacteria penetrate the mucosal defense, and the toxins lead to the formation of intramural gas or pneumatosis. This can be seen with grayscale ultrasound as hypoechoic dots in the bowel wall. Portal venous gas arises from leakage of intramural gas into the mesenteric venous system, which then drains into the portal vein, or even from gas-producing bacteria entering the portal circulation. This can be seen as hypoechoic dots extending all the way to the periphery of the liver parenchyma on grayscale ultrasound. In the progression of NEC, you have extensive transmural involvement, which leads to compromise of the microvasculature, leading to tissue ischemia. Color Doppler ultrasound findings of absent transmural blood flow are indicative of a problem at this late stage. Ultimately, you will have the sloughing of mucosa and submucosa, leaving only the serosa intact. And grayscale and color Doppler here show bowel wall thinning and absent perfusion, which is highly suggestive of impending bowel perforation, necrosis leading to bowel perforation, basically. So that's the sketch from left to right, taking you through this with the image correlates. And as you can see, particularly Doppler assessment is tricky in terms of visualizing gas bubbles, but we'll come to that in a minute. So let's zoom in a little bit more into image findings in NEC. What can you see on abdominal X-ray and what can you see on ultrasound? So in the early stages, you see bowel wall thickening as a result of inflammatory swelling. You can sometimes see pneumatosis, and you can sometimes see portal venous gas. And I should probably say at this stage that the difference between ultrasound and X-ray is that whilst if you see it on X-ray, it's there. If you don't see it, it doesn't mean it's there because it might be visible on ultrasound. Ultrasound can pick up those findings earlier before they are visible on X-ray and later after they've disappeared on the X-ray. It's a transient finding, and ultrasound allows you to depict a much more detailed way these findings. So it doesn't mean when it's not there on X-ray that it isn't there. Similarly, you could even say even on ultrasound, it might mean that there's still a pathology even if the pneumatosis and portal venous gas is not there because it's transient. Now, once the disease progresses, you can see bowel wall thinning as a result of ischemia, ischemic injury, necrosis. Then at any time, you might encounter free gas, suggesting bowel perforation. That can be seen on both. And what you can also see on both, but in different ways, is essentially fluid collection. Now, on X-ray, you will see a whiteout. You will see a white X-ray, a white abdomen, and that's it. Now, the big difference here is that on ultrasound, you can delineate much more whether this is a focal generalized collection with and without debris. So you can much more distinguish between simple and complex free fluid, which is a key finding and which you hopefully will appreciate at the end of this presentation. Specific to ultrasound alone is the detection of motility. So when you have an ileus or not, and the assessment of perfusion. So whether you have bowel wall hyperperfusion, hypoperfusion, or absent perfusion in the late stages. And that's just with color drops. So we're not talking about velocity measurements or anything like that. This is just purely mapping out the bowel wall with color assessment. So you might think that just kind of sorry, just really, that there is a lot of overlap between both modalities with regards to what they pick up, and you could argue that X-ray, and there's a reason why it's still in place because it's easy to use. We're all used to familiar with the evaluation of an X-ray, and you can quite often have on X-ray signs of that corroborate a bowel pathology. However, there are three key weaknesses. One I pointed out already: the early and accurate diagnosis of pneumatosis, the detection of free fluid as a white abdomen, and the perforation. So whilst it is very useful in combination with X-ray, when it comes to answering particular questions, it might not be that useful. So the question is now, what are we interested in finding out with ultrasound that we can't get from an X-ray? And what are these questions and how are we going to approach it? Now, before I go into this, I put this slide up because I wanted to talk to you a little bit about equipment before I do that. And that's because I don't think a lot of machines, when I go out there, have linear probes in their setup. And I would say that's an absolute must if you want to do an abdominal ultrasound scan and you want to look at NEC in particular. You will need a linear probe with at least 10 megahertz frequency range or higher. There are better probes now. We'll have to set the depth setting to really low depth, so 4 centimeters sometimes, or maybe even lower than that. You'll have to be able to use a color Doppler setting with a velocity that goes down to 2 to 3 centimeters. So it's sometimes quite challenging for not high-end machines to do that, although they're all getting better nowadays. And I would say the easiest thing is to just get a preset discussion with the company member to kind of get it all sorted for you. Now, why am I saying linear probe? Now, this is because lateral resolution is roughly 4 times worse than axial resolution ultrasound. So the lateral resolution is primarily determined by the beam width of the ultrasound beam, and this is much better in a linear probe. Why do I say this about color doppler? Well, with the low set, if a low setting does not work, you're going to have a problem, because assessment of viability is this is pivotal. Now, there are new technologies coming in, and I'll talk about this at the end, which are clearly, in my view, revolutionizing how we assess bowel viability. This is an example of how you might approach scanning. So there's different ways of doing it. You can, starting at the top left, you can do just a kind of an S-shaped style kind of scanning. This is the same in the middle. You can do a segmental approach. In the left bottom corner, you see how I do it, which is essentially starting off over the bladder and then moving to 4 quadrants. And this is kind of my way of making sure that I have covered all areas in the abdomen, so that I can make sure that I haven't missed a particular part in the abdomen. Now, you can pick whatever protocol you want. There are some protocols out there. I know that there are protocols out there. But ultimately, whatever you choose has to cover what I've got on this slide. So this is based on my segmental quadrant approach. You need to look for, in the first instance, you look for free fluid, simplex or complex, simple or complex. So simple would be just hypoechoic fluid accumulation without anything else. Complex means there is debris, there is kind of fibrin strands. It looks sometimes like spider webs. So it is much more kind of suggestive of protein deposits and possibly kind of breakdown and breakdown of tissue, basically. Then you look at bowel wall thickness, which can be quite tricky because we're looking at really small millimeter. So we're looking at the range of 1 to 2 millimeters. So that you can imagine is quite prone to intra and inter-observer variability, a large intra and inter-observer variability. You're looking at bowel wall echogenicity, meaning, or echogenic patterns. You can just delineate the layers of the bowel because they are differently echoic. And you can look at peristalsis, pneumatosis, and protein gas. So that all has to be covered, plus a color Doppler assessment in all 4 quadrants. They don't have to be nearby mouth. And what I quite like is the use of compression. So what do I mean by that? So basically, free fluid, if you have a baby on the back, if there are protein deposits, then it's a bit like a snow globe. It will kind of settle. So you might not see that. So in order to kind of move those deposits, you have to kind of shake the tummy a little bit. So you kind of do graded compression or vibration movements to move up in or make these particles float. So moving on to the questions. So the way I approach POCUS, or the way I teach POCUS, is that we're looking at answering clinical questions that will complement our diagnostic approach. We're not trying to solve everything. We're certainly not trying to kind of fish for pathologies. This is just a question that I cannot answer clinically or with any other means. What do I mean by that? So if you take a general ultrasound assessment of the abdomen would be answering a question: is there a pathology in the bowel? So you're not specifying what you're asking for. A focused ultrasound could be that you're just asking, is there general pathology in the abdomen, for example. A focus ultrasound, which is also still in the remit of, for example, sonographers and the radiology services, would be a focus question would be, Is there pathology in the liver? Is there pathology? So there are lots of organs in the abdomen. Is there pathology in the small bowel? So you're specifying, but you're not specifying what you want to know. And a POCUS question would be, is there NEC, yes or no? So you're very definitively asking a question that can only be asked with yes or no. You're not asking for anything else. And in this setting, I think it's really important to stay with that. So the first question would be, is there indefinite NEC, yes or no? Now, many of the changes in NEC are transient. Ultrasound can help detect them when they are still present, but not visible on X-ray, as I said to you before. However, diagnosing NEC early or late is still difficult. This is shown on this slide where I have summarized the sensitivities and specificities for different signs. And when I talk about specificity and sensitivity, I would like to talk about true positives and true negatives. This is just because I think it makes it clearer when you're talking about accurate detection of a pathology or accurate detection of something. So for example, as the specificity is high and the sensitivity is moderate for pneumatosis or port venous gas, there's a good chance that you might still have NEC even if you do not see pneumatosis intestinalis, going back to what I said earlier. However, when it is present, you almost certainly got NEC, even if the X-ray is not showing it. So this is just kind of to put that kind of sensitivity specificity into a clinical context. And again, at this top tip, or I should probably say at this point, that pneumatosis is not pathognomonic for NEC. It is pathognomonic for an inflammatory process in the bowel. And I keep on emphasizing that because you can see it in adults. You can see it in any other age group. You can see it with different pathologies. It's just basically a reflection of a pathophysiological process at a given point in time. What do I mean by that? Well, you could see pneumatosis in CMV colitis. I've seen this. You can see pneumatosis in complex protein intolerance. I've seen that. We have had 34, 35 weekers, a bit of bloody stools, slight distension of the abdomen. Well, baby, no CRP, nothing else. Even maybe some pneumatosis on X-ray. What do you do with that? Even especially if you see it on ultrasound as well. That's not necrotizing enterocolitis. So it is important to always contextualize that with the clinical picture, because pneumatosis is not diagnostic of NEC unless you have everything else that aligns as well. Also, if you find free fluid, for example, the diagnosis of NEC is highly likely. In other words, your true positive rate is high, but your true negative rate is rather low. Now, as you can see, diagnosing is a little bit tricky because you have to contextualize it. You have the whole thing about true positive and true negative is a bit tricky. If you find something, yeah, that's fine. But if you don't, you're still not sure. Now, it's the true value of ultrasound comes when you have established the diagnosis and you're trying to figure out a little bit more what's going on. So if there's a whiteout in the abdomen, for example, then this is where ultrasound can really help, because it allows you to differentiate between paucity of gas, free fluid, and the character of the fluid, which is extremely important. Which leads me to the kind of more important question, is there failed medical treatment? So when you look at these figures now, it becomes hopefully a little bit clearer. So once you've established the diagnosis, the sensitivity and specificity of free fluid, especially complex free fluid, is extremely high. Free fluid, you should be starting to talk to the surgeons. If you don't have it, you can probably wait a bit longer. So when do you need to push for the surgeons? Well, it depends. Obviously, if you have a perforation, very clear, you move the baby to surgery. However, if you don't, then it's more about, is there viable bowel or not? Is there necrotic bowel that needs to be removed? So essentially, when you can prove that there's dead bowel, then you push the surgeons. And this is best shown when you find an area that has no perfusion whatsoever. Here, the true negative rate is high and the true positive rate is low, meaning if you see the slightest bit of perfusion, there's probably no necrosis. However, if there is no perfusion, the bowel might still be viable and not necrotic. Now, there's a problem here, and you can see that from the figures, from the sensitivities and specificities. That's currently based. Those data, those numbers are based on standard color flow assessment, which might fail to detect perfusion due to its technical limitations. And this is why it's important to look at your hardware and your software. As you will see later, the specificity is likely to get better with more advanced color imaging technologies. Okay, so let's take a closer look at some ultrasound images. Now here you can see on the right-hand side a transverse view of someone with necrotizing enterocolitis where the bowel is swollen and there is pneumatosis. I don't think I have a cursor to show, but you can see in the right top corner a ring with white dots, and the dots are spread around the ring. There's not much inside, and you can see it's quite thick, that kind of area. On the left-hand side, you have a tangential view of that. So it's like a sausage at the top end that extends from one end to the other. Now, important here, can you see my cursor? So important here is to identify that white dots could be, you need to distinguish basically between intraluminal and extraluminal gas accumulation, because it can very easily mislead you. Bowel content is quite often mixed, has gas in there, and you quite often have bubbles that accumulate at the top and could make you believe that there's pneumatosis, so little white dots here. However, if you see white dots at the bottom, so gas rises, so if it's at the bottom, it hasn't risen, so then it's probably trapped in the bowel wall. So that would be a confirmatory of pneumatosis or gas trapped in the bowel wall rather than in the lumen. Obviously, if it's around it, then it's even more convincing. Here you can see portal venous gas. So on the left-hand side, I've shown you in a sketch where you would put the probe to look at that. And then on the right-hand side, you can see the gas bubbles extending all the way to the periphery of the liver. So now we come to free fluid assessment, which is a well-established finding, and the technique is very clear for that across all ages. The FAST scan is one of the kind of most well-known kind of assessments when you look at that in trauma. You are looking at fluid in the Douglas and Morrison pouch. Why? Because as you can see on the sketch, they are the lowest points in the body in a supine patient. If you were to scan, you would put the probe over the bladder, just over the symphysis for the Douglas space. And if you want to look at the Morrison pouch, you would put the probe just below the costal margin on the right. You would always try to do that in 2 planes, simply because it's, again, standard to confirm, well, in any ultrasound really, a pathology in 2 planes. So this is an example of simple free fluid. So you can see here in the Douglas pouch that, so for those of you who are not familiar with abdominal ultrasound, so on the left side is cranial, and the right side is caudal. The top end is anterior, the wall, abdominal wall, and at the bottom you can see the spine. And you can see the fluid accumulation. I'm trying to see whether I can get this cursor to show. You can see accumulation in the Douglas space just behind the bladder. So you will see the symphysis, which is kind of an area that is slightly hypoechoic, followed by this oval-shaped structure with hypoechoic content, which is your bladder. And behind that, you have your simple free fluid, just all black. Now, this is a bit more interesting now. So on the left, you have the sketch that explains what you see on the ultrasound scan. You have the liver coming in from the left. You have the kidney underneath. You have the below the kidney, this kind of slightly dark structure that's kind of going upwards, which is your iliopsoas. And above all that, you have black, which is free fluid. Now, between the tip of the liver and the kidney, there's a little kind of strand, which would suggest fibrinous strands and complex free fluid. It can be as subtle as that, or it can be very obvious. This is work from the colleagues at Sick Kids in Toronto, who very nicely summarize here the evolution of the bowel wall injury with NEC. So starting on the left, you have a healthy bowel with normal thickness, normal perfusion. And as the injury evolves, or as you develop NEC, the bowel in the initial phase swells up, and you have hyperperfusion. The body tries to kind of fix that. If it doesn't go in the right direction, you will find that the swelling is still there, but the perfusion, as the bowel becomes less viable, starts disappearing, and eventually the tissue starts degrading or decomposing, and you get very thin bowel, all the way to the point where you don't have any perfusion in it at all, which is seen on the right. So these are images from our unit. You can see here on the right side, similar to the one that I showed you at the beginning. So a swollen bowel, quite thick, with pneumatosis and hyperperfusion. A lot of red, a lot of color dots in there. And on the left side, you can see that some of the bowel is perhaps a little bit thinner. There's fluid accumulation between the bowel, and not clearly visible complex, predominantly at the moment, simple free fluid. Now, when we move on and things progress and they don't progress in the right direction, you can see that here on both images, the bowel wall is quite thin. This is bowel filled with stool, and you can see that it's like a white line outlining the stool content. That's it. So you've lost the echo texture, you've lost the thickness. And on the left-hand image, you can see this white kind of band-like structure, which is probably fibrin strands coming from somewhere. Now, this is when it's getting a bit more interesting with regards to assessments, or when we're looking at establishing viability. With the color Doppler, you would have to set your velocity quite low, as I told you before, and you can see either as you can have as on this image on the left side in transverse view or in tangential view, the main feeding vessels going into a coil-like kind of pattern that surrounds the bowel. So it's either kind of a V-shaped Y-shaped appearance, or like a little tree. Now, when you look at tangential views, you get this, and there's a lot of different terms that are being used in the literature for this kind of coil-like microvasculature that is hyperperfused in NEC. People use animal names, whether it's zebra stripes, tiger stripes. It depends on what animal you prefer, really. But they have a lot of names for these findings, and this is a classic kind of hyperperfusion finding for inflamed bowel. Now, when you have color flow set, and you can see that the frame is quite big, and you have color sparing, then that's when it starts getting a little bit worrying. At the top, you can see like a darker area that really, where you would really struggle to identify any bowel. It looks almost like a boat or like a sausage. It doesn't really give you much detail, and the color is spared. So you're wondering whether this could be potentially non-viable bowel. This is another example here where you're looking at that. Again, you kind of have the frame is large, and you can note here the depth. The depth is not great. So it's just, we're looking at 3 centimeters depth in a very small premature baby. And you can see that there is an area in the middle that doesn't really kind of look like bowel anymore, and there's a lot of color around it, but that area is spared. So you would worry here that this might be non-viable bowel. And finally, neoperitoneum. So you can assess perforation with ultrasound. I'm not saying you can't. This here shows you on the left-hand side images where there are white dots between the liver and the abdominal walls. You can see that line of white dots over there, which it's a subtle kind of, it's a suggestion that of air leak. It's probably a subtle kind of air leak. It's not a big air leak. And you can spot that, but you can also easily miss that. I'm not so sure of how much diagnostic or clinical value is, because I'm not sure whether you would actually proceed to do something about it surgically. What you're more interested in is the large perforations, which you would see on both quite well, an X-ray and an ultrasound of the bowel, of the abdomen. In large perforations, you probably would have a similar appearance to what you would find in a lung ultrasound scan. So you would have these kind of reverberations, and that's about it. So I'm not sure how much value that has. But this is more important here. So, as I mentioned before, conventional color Doppler struggles to detect sometimes the extremely low velocity flow, which effectively affects the diagnostic accuracy. We talked about true and positives and true negatives. And that's to do with overlapping noise and tissue motion. So tissue is in motion and overlaps with other things. So it's not just, we're not just picking up what is in the vessels, we're just picking any motion. And as it relies on velocity intensity analysis alone, you can't really separate that out sometimes very well. Now, microvascular flow imaging does something really clever. This is an advanced ultrasound technique designed specifically to detect slow-moving blood in small vessels. And it offers a greater sensitivity than conventional ultrasound methods, because unlike traditional color and power Doppler, i.e. non-directional color Doppler, it effectively suppresses the motion artifacts without losing weak signals from the microvascular flow. And how does it achieve that? Well, that's really clever. What it does is it basically analyzes spatiotemporal coherence, which helps to distinguish between true blood flow and tissue motion artifacts. So what do I mean by that? So in that sketch here, you can see that at low velocity, if you just pick up low velocity, you can't separate it out. However, what the researchers have found out that is that the movements of tissue are quite regular, almost like I have a certain pattern, whereas the movement of blood is more random and scattered. So that has allowed them to spatially separate out low velocity and filter out those that are more kind of regular, I guess, from those that are probably less regular, leaving you with just the blood flow. Now, machines have different names for it. Again, it's not just, there's no standard name for that technology. It's called, what our Philips is called microflow imaging. Other technologies call it micro flow, or some call it supersonic image. I mean, there's all sorts of names. So you just have to check with your machine whether it's there or not. You can add it on if it's a new enough machine. And here I'm just showing you a comparison of what you would see with microflow. So on the left-hand side, you have your standard color flow with direction. You have then your power Doppler, which both are based on pulse wave Doppler. Microflow is not based on pulse wave Doppler. The only power Doppler is probably some of you might not even recognize that, because it used to be on the machines, on the older machines. It's pretty much gone out of, it's probably not available anymore on some of the machines. I mean, it's not really necessary, really. And then on the right side, you have your microvascular flow imaging, which is a much more detailed depiction of the microvascular bed. So this is an interesting example, or to highlight how much this microflow imaging use will help you. This is an image from colleagues from, I think it's a collaboration from Sick Kids and Spain in Barcelona, where they, on the left-hand side, have a baby where they think it might have NEC. And there are some areas, as you can appreciate, that don't seem to have color flow. So the worry is this dead bowel? Is this non-viable bowel? Do we need to get the surgeons involved? Now, on the MFI Doppler, you can see that all the bowel is picking up flow. So that is viable bowel. So this is not dead bowel. So therefore, you don't need to call the surgeons to discuss surgery. So you can see here the quite striking difference with regards to picking up those low velocities. Now, in this image, this is from our department, we have a Philips, and the left side shows you, you probably now have trained your eye a little bit into it, an area that looks more like matted bowel. So you can't really tell anymore what's bowel, what's not. You have a fluid accumulation. It looks a bit odd. It's probably not all right. Is it viable? Not sure. Now, the color Doppler at the bottom would suggest that there is non-viable bowel. And the microflow image on the right top confirms that, but in a much better way, because you can see much more clearly which parts are not viable. If you compare the top right to the bottom one, you can see that the area that is actually non-viable is smaller. So this is quite important in delineating, is that truly non-viable bowel, and what is the area, what's the extent of the non-viable bowel. So moving to another technology that I'm more and more interested in and hopefully will start using soon is contrast enhanced ultrasound in NEC. Now, the use of contrast enhanced ultrasound is gradually filtering down into neonatal care. As always, we're the last ones when it comes to any novel kind of developments. But microbubble usage is growing in neonatology. And the microbubble agent, basically what it does, it remains strictly within the vascular bed to enhance echogenicity of the blood flow without diffusing into interstitium. So it's strictly stuck in the vasculature. And these microbubbles oscillate in response to ultrasound, producing nonlinear harmonic signals that can then be selectively detected to distinguish blood flow from surrounding tissues to assess tissue perfusion. So you would think, well, that's perfect. And actually, it is pretty good. So this is work from, I'm not entirely sure whether it's North America or China. So I know that the two groups that are doing this are in China and North America, using contrast enhanced ultrasound to assess bowel viability. And you can see, I mean, it doesn't take you much to recognize what is dead and what isn't. Where all the dots are, that's still viable bowel. So it's the contrast is being picked up. It's washing in and washing out. And then the area that has got nothing is dead bowel. Now, why I think that contrast might be the next step up is because of this. In normal physiology, the mesenteric and bowel wall microcirculation is coupled. So you have your SMA, it goes into kind of tributary, so it's a bit like an estuary, and then it kind of follows quite quickly. There is no delay, no lag time. So it's a coupling between mesenteric bowel perfusion and microcirculation of the bowel. This means that your enhancement of the bowel wall follows arterial inflow almost immediately. So if you wash in the contrast, there will be no delay in that. However, if you have ischemia, systemic or local autoregulatory vasoconstriction, or endothelial dysfunction, they delay and disrupt this transition. So what does that mean? So your contrast imaging visualizes this uncoupling. It will make this kind of delay in mesenteric to bowel perfusion more obvious, allowing you basically to use it as a functional biomarker of compromised viability. So what do I mean by that? Well, in other words, the delay of the wash in and wash out phase can suggest that you have bowel that is compromised but not dead yet. So far, we've been talking just, is this dead or not? Like a binary question, going back to what I said at the beginning. Now, this is moving to a more refined assessment where you can actually, especially if we are doing it sequentially or repeatedly, you could look at bowel and say, okay, this area is not looking great, this area is okay, and then see with repeated contrast enhanced ultrasound imaging how it evolves and whether actually some area might become non-viable. So this is, I think, a really interesting kind of evolution of imaging and perfusion assessment of the bowel. And now I'm taking it really one step further with regards to this. So this is work that's been done in inflammatory bowel disease. So this is moving away now from NEC. But I mean, as I pointed out before, they're all kind of part and parcel of the same kind of pathophysiological mechanisms. It's just a slightly different patient, but the principles are the same. So this is work that's been done in inflammatory bowel disease, looking at whether you can actually quantify the severity of bowel compromise. And this is not just based on the fact of, with regards to assessing the wash in and wash out phase, but also the amount of contrast being taken up or not, and that allowing you to quantify which bowel is more affected or not. So you can then all of a sudden have a whole range of assessment from which bowel is affected, which bowel isn't, how much is this bowel affected, and how much is compared to another area. So we would be moving in that direction, which I think is quite exciting, and I'm sure it will kind of filter down. This is work from 2018, and it won't take much to kind of go into that direction. And obviously, a presentation has to have nowadays AI. I think, again, in inflammatory bowel disease, bigger patients, but it's coming. So it's already there in liver assessments. It's already there in other areas. It will come with bowel as well. So this is work that's been done to produce a more kind of automated, reliable, more objective kind of way of assessing bowel wall compromise. Bowel wall thickness is here what is displayed, allowing you to have that kind of more precise assessment of bowel wall thickness. We're looking at here millimeters, and have that in an automated way so that you can say, okay, this is abnormal and this is not abnormal, rather than a more kind of subjective assessment. So in summary, findings with high sensitivity and specificity for neck complications and need for surgery are, if you break it down to the core ones that I think most of you would be able to do with very little training, it's focal fluid, free fluid assessment and complex free fluid detection of complex free fluid, following that kind of principle of looking at the Douglas and the Morrison pouch, and the assessment of absent bowel perfusion, with the caveat that you need to look at your machine, you need to look at what the machine can actually deliver, and if you have microflow, then I would use microflow in addition to make sure that to do that. Somebody raised their hand. The newer developments of microvascular will, and certainly AI enhanced, will definitely improve that. And I think in the future we'll have more on that, which will allow you to assess bowel more easily and in a more standardized fashion. So minimizing that kind of threat of intra or and interobserver variability or reliability. If I have managed to kind of make you interest you in necrotizing enterocolitis ultrasound or assessment, then I would direct you into this kind of module. This is something that I produced with a radiology colleague a while back for the Royal College of Radiologists. So this is part of a learning module for the radiology trainees, but it's accessible to anyone. And I will leave you with this paper, which basically is asking whether we should starting to push a little bit more for introducing that as a standard. Thank you.
Thanks, Ramon. That was an excellent talk, a real massive and fantastic overview of neck of ultrasound in necrotizing enterocolitis. I'm just going to introduce our moderators quickly, if that's okay. So I've got Samantha Dixon, who is an ANMP who's just recently started in Leeds, who's going to be moderating, along with Dr. Amitabh Asur, who's a consultant neonatologist who I know has a big interest in point of care ultrasound, who's at Burnley General Hospital. I can see we've got a couple of questions in the QA box, so I'll hand it over to Amitabh and Samantha.
Thanks, Liam, and fantastic. I'll quickly go to the questions in the chat. One of the questions is, I don't know if you can see it, it's about the differences between preterm and term infants when you do the POCUS neck for bowel assessment. What would be your take on that?
There is no particular difference because it's all qualitative assessment. So you're not really measuring things. You're right. If you were to look at measurements, for example, bowel wall thickness, you might want to then start looking at what is a normal measurement for a preterm or a term baby. But I would strongly advise not to go there. It's quite messy. Any measurements really. Because it depends on so many different factors. So I would stay with qualitative assessments, yes or no questions. Is there free fluid? Is it complex? Is it not? Is there perfusion there? Yes or no? And with better Doppler technology, you'll be able to rely more on that.
I think the same person asked that have you used it to sort of monitor post-lap patients, post-operative necks? Have you seen?
Yeah, I have actually, and in fact, I remember a case where the baby needed to go back to theaters because there was more. The baby went through a two-phase kind of period where it kind of got better after coming back from theaters, and then it started getting worse again. And then there was this discussion about what's going on, and in fact, it had developed more necrosis, which needed to be removed. So you can do that definitely. You can monitor that evolution, and again, it's if you put it into clinical context. Surgeons try to minimize the amount of bowel that they remove. That doesn't mean that all the bowel that is left inside is going to be viable, and then some of it might still kind of deteriorate. So it's definitely a tool to monitor that. Absolutely.
Another question which is very interesting. So you mentioned it. It's about potential confusion in neck and FPIs when you look at pneumatocysts. And we certainly had a child who was who had floated pneumatocysts on the X-ray. Looked incredibly well. This was a post-term ex-preemie who was introduced to formula and had every parameter normal. So I was called in a weekend, and I had scanned and looked a completely normal sort of bowel vasculature, peristalsis, etc., but did have pneumatocysts. We sort of had to stop feeds and introduce NeoFOCUS, and sort of it reduced in the next 3 to 7 days, and completely we didn't have to treat with antibiotics. What is your experience in we have seen a couple of such babies actually who mimic neck but are FPIs?
I think it's quite tricky, isn't it? As a clinician, you need to have nerves of steel to have a well baby who's probably maybe have had a bit of blood in the stool, has a bit of a distended abdomen, is otherwise well, but on X-ray and maybe on ultrasound or one of the two has got pneumatosis. I mean, you're gonna be, I think everyone would say you'll be quite brave to not start antibiotics and so forth. I mean, probably kneel by mouth for a short period, but it might help you tailor your kneel by mouth period. It might help you make a decision about not using antibiotics. You'd be quite brave to ignore it and just say, just keep going, give a bit of hydrolyzed formula. It's a tricky one. We've had that, and I'm not sure what to do with that. Yeah.
Yeah, I think we also started antibiotics, but we could quickly stop it because the inflammatory parameters came down, etc. So it helped us guide it.
Yeah.
Ramon, I have a question because it's a more technical, sort of a more organizational question. I think we do ultrasounds in our unit, but the main problem that we face is we are a non-surgical unit, and when we discuss with surgeons, the buy-in for an ultrasound abdomen to guide surgical referrals is not always greatest. It's sort of, I'm sure you'll agree to that, and we have had multiple conversations on standardizing this. What do you face in South near Brighton, and how do you sort of address it?
We have the same. So I think it's I don't know. I have tried to encourage our surgeons to buy in a little bit more, and we've gone through different colleagues, and eventually some colleagues have been there in Brighton, and surgical team have kind of embraced that. But I think it's still a very traditional approach, and they're not really open to this. I'm not sure how to breach that. My suggestions in the past were that I could teach them, I could train them to do it, so that it's not coming from a clinician. It's a surgeon who assesses and makes a decision. But that didn't go very far. So I don't know. It's a bigger question because it's still non-imaging specialists doing it, and I really don't know what the answer is. I mean, my suggestion would be to take it to them and make them scan. But then obviously, if you are referring out, then that's not going to be possible. In my department, quite often they have in the past asked for a radiologist to confirm what I found, and then the radiologist asked me what I saw, and then they just confirmed it. So because they quite often are not trained to scan for NEC, the radiologist, and they will struggle themselves. So this is why I did this module for the Royal College, because they're not trained to do it either.
Thank you so much. Is there any other questions?
I can't see anyone with any other questions, but if anyone does, please put them in the Q&A box. But I do just have a question, Raymond. First of all, thank you. That was a really interesting presentation, especially for someone who's quite new to abdominal POCUS. But my question is, at what point, like I assume that you would scan when you have your first clinical concerns of NEC.
Yeah.
And then how often afterwards would you then re-scan to check for progression or regression of the disease?
I think this is the stuff that where I think research needs to go in a little bit more. The honest answer is I don't know, because these findings are transient. So if you pick up, this is what I was saying at the beginning, establishing the diagnosis of NEC is tricky because you can miss that window whether you pick nematosis or it might not be there yet. So you'd have to kind of regularly scan. The question is where the balance tips in terms of doing it too often and so forth. And I mean, if you do a full abdominal assessment for NEC, it takes a while. So I still, yeah, I mean, the surgeons want their X-ray 6-hourly. I'm not sure whether I would do that with the ultrasound, but if you wanted to follow that, that's what you would need to do. I don't know whether it's based on hard evidence or it's one of those things that have crept into practice. So the diagnosis is tricky. If you put the probe and you have clear findings, then that's it. You don't have to worry about it anymore. It's more when you don't, but you're still worrying about it. How often do you do it? Not sure. Really not sure. I mean, you could do 6 hours, you could do 12 hours, you can do once a day. The pathophysiological processes take their time and they're not necessarily always the same. Some babies deteriorate very quickly.
And the question also is, do you have the person to do the scan all the time? That's a big thing, isn't it?
No.
If you want to do it,
it'll be me or nobody.
Exactly. So
yeah.
So that's the limitations we often face, because if you don't have a radiologist who's trained in that, or a neonatologist who's, if they're not on the shift, you can't really do it. You have to go back to X-rays, isn't it?
Yeah. And I think this is why the other question, so is there medical treatment failing, or do we need to call the surgeons, much better, because they are not necessarily questions that you want to answer immediately. You're kind of pondering a little bit more about it. You're thinking a bit more. You might ask a colleague to review with you the baby. So, and that the context, your scan is much more helpful, because if you then go to your colleague and say, not sure, but actually I found complex free fluid, there's a lot of complex free fluid there, then you might think, yeah, okay, well, you're giving yourself the answer. But that's not going to go away that quickly. Complex free fluid, once it's there, it's there. So if you don't see complex free fluid, you can probably wait. If you see complex free fluid, you're pretty clear. It will not disappear that quickly. So if you do the scan a bit later, it won't be gone. So you don't have to worry about that. And similarly, non-viable bowel, the only problem with non-viable bowel is the technology. But once it's dead, it's dead. So that's not going to change.
There's another question which says, I think the question we all want to ask is that how to develop the skill required to a person to be competent. Not sure there's a right answer to it, but the process of mentorship to develop. How many scans are required for a person to become competent? That's a question that's being asked. And how do you develop the skill, and sort of the process of mentorship, I think, which is quite the question we're all asking, I guess.
I don't know. I mean, I think it's the same question as for many other scans. So, I mean, I'm not sure whether we have that answer for all the other things as well. So I really don't know. I would say, and we were just having this conversation before the meeting, that I think with regards to whether it's echo or lung, if you start with basic assessments that are quite robust and reliable and simple to do, then you probably don't need to do that many. So assessing full free fluid is quite easy, and this is what I teach on the course as well, in particular, and then perhaps a little bit more into color Doppler or color microflow assessment. And I would say that's where I would leave it. If you want to take it to the next level, it's a little bit like trying to kind of look at a PDA or doing a full structural assessment with all singing, all dancing things, then that probably takes a bit longer. But you can quite quickly learn to assess full free fluid. That doesn't take you long. Everyone is slightly different, but I would say that can be embedded into a kind of course and to a kind of quick mentorship program quite easily.
Thank you. Certainly, radiologists who have experience also helps. Because certainly now we had a very good fortune to have a radiologist who was interested, so we could develop sort of a reflecting of one another to see the scans. The question which says that, is there a accredited abdominal course which people can undertake for accreditation? Did you put in the link in your chat, the one course that it'll be helpful, I think, the last slide.
I can put that in.
That'll be quite helpful.
So I teach in Southampton on the NeoBus course. So that's a course that we do in Southampton. I'm not aware of another course teaching specifically this. I think the Cactus course was looking at that, and I think the NeoFOCUS group was thinking about it, but I'm not aware of anything at the moment. There's no accreditation system. The reason why I can do it is because I trained elsewhere in another country. So that's why, and then I developed that further over here. I think at the moment here, there is no established pathway for this, but it's probably coming. Like with lung, it will filter into Cactus courses and other courses. We do it in, well, I teach in the Neobus course in Southampton, in Southmead, in Bristol.
Thank you, Ramon. It'll be helpful to have the link.
Yeah.
Just got one question as well. Reversed or absent end-diastolic flow in Doppler of the SMA or celiac axis often do not correlate well with the clinical signs of NEC. So does hyperperfusion features in bowel wall by ultrasound diagnostic of impending NEC?
Okay, can you repeat that question? So SMA doesn't correlate, or sorry, I didn't.
So the end-diastolic flow in Doppler of SMA or celiac axis often do not correlate well with the clinical NEC. The question is, does hypoperfusion features in bowel wall by ultrasound diagnostic of impending NEC?
Impending NEC. It's an interesting question. It's usually a late sign. It's not necessarily an early sign. So I don't think you could. Hypoperfusion is tricky. Hypoperfusion is tricky because you're not really quantifying it. So how you need to have a reference point or reference value or something to refer it to. It's very subjective. So this is why I would be careful with trying to use hypoperfusion to anticipate the evolution or the development of NEC. What I'm referring to as it stands at the moment is the detection of absent bowel perfusion, which is very clear cut. Anything else is tricky. So I'm sure that you could use that if you had an objective way of reliably quantifying that kind of level of hypoperfusion. I'm sure there is a way there to potentially predict the evolution of NEC. But as you know, it's multifactorial as well. So there's all sorts of things. And obviously the perfusion responds to the injury or the insult. So that might change once you've had the insult. So I don't think you can use that. I don't think you can use that. And SMA and celiac Doppler flows, yes, are notoriously tricky to assess and not particularly reliable. You are dealing with different dependent or downstream areas. So you're looking at one that goes into a solid organ versus one that goes essentially into an estuary type kind of part. So yeah, they're not the best. You're right. But I wouldn't use that for anticipation of NEC, not as it stands at the moment. Maybe with, well, who knows? Maybe with contrast imaging, we might be able to kind of start looking at that. But I think that's a long way gone. That will take a while to anticipate that.
Okay, but thank you ever so much, Ramon, for a fantastic talk about NEC. We look forward to seeing you guys all again in 2 weeks' time at the next seminar for the NeoFOCUS group. Okay, thanks, guys.
Thank you.
Thank you for watching. If you enjoyed this, please check out the other webinars on our channel.